PTA students. Hope you guys are having a good day. So we're going to start going through the kinesiology of the lower extremity. Here is our roadmap for the hip. We'll go through movements, landmarks, muscles, some functional takeaways, and then some common pathologies, most of which we've covered in Rehab 1. So at the hip, we have flexion, extension, hyperextension. I typically still refer to that as extension. Most clinicians do. Abduction, adduction, and then lateral rotation, which is also external rotation, or medial rotation, which is also internal. So for the Boney landmarks, on the ilium, we have the ASIS at the front, the PSIS in the back, the iliac crest, which is that arch. On the ischium, we have the ischial tuberosity, the bones you sit on. On the pubis, you have the pubic tubercle, and when it connects to the other pubic bone, there's a symphysis in between. You'll see on the next slide. And then the hole right there on this bone is the obturator foramen. So on the body, that bone looks like this. The ASIS is the green in the front. PSIS is where it connects in the back, connects to the sacrum. The ischial crest is the arch that you can feel on top of your hip. The ischial tuberosity is that butt bone you feel. The bottom, then the ischial tubercle and pubic symphysis are right here. Symphysis is where the two bones connect. And again, the obturator foramen. Landmarks of the femur. So we start out with the femoral head down to the neck. The greater trochanter is the outside portion that you can feel when you palpate your hip. And then the linea aspera is on the posterior aspect, and that is one of the attachment sites. So the vastus lateralis, vastus medialis, short-headed biceps femoris, and portions of the adductor. So portions of the hamstring muscles and the adductors connect on this line right here, the linea aspera. There are medial condyles and lateral condyles, as well as medial and lateral epicondyles. We had that discussion in class one time as to whether there are epicondyles on the knee or just the elbow. Here is your answer, both. So the medial and lateral condyles and epicondyles are at the distal part of the femur. Also with the greater trochanter, that's the attachment site for your gluteus medius, gluteus minimus, and most of your deep rotators of the hip. Then on the tibia, going down into the leg portion, from an anatomy portion, if you're just a general term, the top of the leg they call the thigh, from the hip to the knee. The bottom of the leg they just call the leg. So like with the arm is the forearm and then the arm. And then for the leg it's thigh and leg. But we have our tibial tuberosity is the main thing I want you to remember on the tibia, which is where the patellar tendon attaches. Also is the tibial plateau. That's actually just the top portion of the tibia, but it's somewhere we palpate to see if somebody has like a torn meniscus, anything like that. So that might be one to remember. Okay, so for our hip structures, we have the labrum. So it's called the acetabular labrum if we're talking about in the hip, and then the glenoid labrum if we're talking about in the shoulder. So since we're on the hip, the labrum is that fibrocartilage. The fibrocartilage is the strongest cartilage versus the articular cartilage is the more smooth cartilage that makes everything move smoothly. But although it is strong, it can still be torn, and sometimes it does, especially in runners or someone who has a repetitive trauma to that area. Then we have ligamentum teres. I'm getting tongue-tied. Ligamentum teres, which connects the femoral head to the acetabulum. It is most tight when you abduct your leg, when you abduct the hip, and it can be torn during a bad break. Also the joint capsule we will go to next. Okay, so the capsule is comprised of 3 ligaments. They are all connected in like a rotational fashion, which increases their support and their strength. As you notice, the anterior portion has a lot of coverage from the capsule. And if you look, here's the anterior portion of the hip. A lot of the femoral head is sticking out, is not covered by the acetabulum in the front. Versus the posterior hip, almost all of the femoral head is covered by bone, by the bony acetabulum. So you need less capsule in the back than you do in the front. But that also means that the back typically is a little more tight. The front is typically a little more loose. So then for joint mobilizations, if you think about, almost always we do posterior glide because typically that's the area that's the most tight. So of course we only do that if we're wanting those movements to increase, but which would be hip flexion and abduction, those types of movements. But just from an anatomy perspective, you could see why the posterior capsule would be tighter. It's much smaller space. There's much more bony coverage. And so it's a lot more firm versus the front may allow some wiggle room, may get loose. If you ever are a chronic dislocator, it would be a loose anterior capsule. And the other thing is, if for some reason there's too much bony coverage, that's going to cause impingement there. So you're probably going to have limited motion, especially flexion, possibly abduction, and then impingement of the hip. So having more bony coverage wouldn't be that great because we need a lot of mobility to flex our hips. All right, I think I said all of those highlights. Okay, so for our hip structure, another is the inguinal ligament. It attaches to the ASIS and down to the pubic tubercle, and we'll mention that later in the functional because it is the ligament you hang on. When I talk about hanging on your ligaments and you're basically arching your back and extending the hip, it allows this ligament to be tight and gives you that support from the ligaments, and you rely less on your muscles. So we'll look at that in the functional components in a moment. Okay, the IT band is another structure of the hip. Of course, it goes from the iliac crest all the way down to a portion called the Gerdy's tubercle below the knee. It also attaches to your tensor fascia latae, TFL, and then your gluteus maximus is attached by some fascia as well to the IT band. So we're going to move on to our hip muscles. The first being the iliopsoas. So the psoas has psoas major and minor, and then the iliacus. They join together, and so we typically look at them as one muscle. It's actually two separate muscles, but both do hip flexion, and both are innervated by the femoral nerve. However, psoas also assists with your trunk flexion and with hip external rotation, trunk side bending as well. So it does more movements. And remember, the iliopsoas is one of the muscles that typically is tight and needs to be mobilized. So if somebody is stuck in the anterior trunk lean, or if they have limited hip movements, that psoas is important to mobilize. Here are your adductor muscles. Screen just went out. Okay. All of the adductors except the pectineus are innervated by the obturator nerve. So this first one, the smallest one up top, is the pectineus. It's innervated by the femoral nerve, which is the nerve that innervates a lot of your quads and other muscles of the hip. But the remaining adductors are all innervated by the obturator nerve. Notice they are so close to that obturator foramen. So we have adductor longus here, adductor brevis, adductor magnus, and then gracilis. Those are some of your adductor muscles. The hole right here in adductor magnus is called the adductor hiatus, and your femoral artery and vein actually go through that hole and go backwards. So they start in the front, they go through that hole and go backwards to the posterior knee, and then their name changes from femoral artery, femoral vein to popliteal artery and vein. So that's in this little hole in the adductor magnus where they cut through and their name changes. With the rectus femoris and the sartorius, we have the femoral nerve innervating both of those muscles, just like pectineus. But the rectus femoris, remember, it's the only one of the 4 quad muscles that passes the hip joint. The other connect lower and are not a 2-joint muscle. But this one is, and it allows the hip to flex as well as knee extension. Of course, knee extension is the primary movement of the quads. And then sartorius takes you to that Peter Pan formation. You flex the hip, you abduct the hip, externally rotate, and flex the knee. So you're kind of in that Peter Pan or Captain Morgan type of position, and that is all done by sartorius. With the posterior hip, we have the gluteus maximus. We know that extends and externally rotates the hip, and it is innervated by the gluteal nerve. We also have piriformis. So this is an anterior view. You can see it sneaking through there. And here's the posterior view of the piriformis, which abducts and externally rotates the hip. And that is innervated by the nerve roots L5 through S1. And obturator externus, which is right here, is responsible for abduction as well and innervated by the obturator nerve. Quadratus femoris, so that is down here, the square muscle down at the bottom, adducts, and externally rotates, and it is innervated by the quadratus femoris nerve. If all of them had a nerve that was just named after them, it would be a lot easier, but at least this one does. And then the Gemelli brothers. So we have superior gemellus and inferior gemellus. And they are known as the Gemelli brothers. They abduct and flex the hip. Superior gemelli, or gemellus, is innervated by obturator internus. And inferior gemellus is innervated by the quadratus femoris nerve. Pause. Okay, so I was explaining the Gemelli brothers. Sorry, I had to pause the video. Dr. Putnam was calling me. And so the way that I remember the Gemelli brothers, so the Gemelli, or gemellus superior, thought he was better. He wanted to be on the inside group, and so obturator internus is the nerve he chose. Gemellus inferior has the quadratus femoris nerve, which is the same one quadratus femoris had. Inferior. Now I've forgotten how I remembered it. The superior want to be on the inside, so quadratus internus. Oh, and then inferior gemelli, quadratus femoris. He wanted to sit on the bench below him, B-E-N-C-H. Oh, because he was the bottom bench. That's how I remembered it, bench, B-E-N-C-H. He was sitting on what looks like a bench underneath him, hanging out with the quadratus femoris. They were sharing a nerve. Okay, I don't know if that helps you or confuses you, but that's how I tried to remember it. Okay, hamstrings, of course, we have biceps femoris. So we are looking at the back of the leg now. So this is the right leg. This is the most lateral, biceps femoris. And then we have semitendinosus, which you remember has that large tendon that kind of you can see when you tense it up on the inside of your knee. And then we have semimembranosus, which has a shorter tendon and is somewhat in between the two muscles, still kind of lateral to that. And all of them flex the knee, and all are innervated by the sciatic nerve except for the long head of biceps femoris. The long head portion is innervated by peroneal nerve. So all the hamstrings are innervated by the sciatic nerve except for the long head of biceps femoris was the peroneal nerve. You know, the long head had to choose something else. He thought it was a little better than everybody else. Okay, so our lateral muscles of the hip, we have gluteus medius, woo, my favorite. You know, it abducts and extends. We typically strengthen it in that middle portion between abduction and extension, about a 45-degree angle. And you know that its primary job is to stabilize the pelvis, especially during single leg stance. It is a primary stabilizer, but when you're using it for a mobilizer, it abducts and extends. Then, of course, gluteus minimus assist with that abduction. And then TFL, tensor fascia lata, is responsible for flexion and abduction. So all three abduct, but gluteus medius also extends, TFL also flexes. But all three are innervated by the superior gluteal nerve. Functional takeaways. So I'd mentioned this inguinal ligament. Whenever you lean back, like this position this guy is standing in, then that inguinal ligament is at its tightest point. So it is pulling away from the two muscles. And you can actually use that strength from the ligament in order to kind of secure your standing posture. So if you're very weak, like somebody with muscular dystrophy or something like that, or someone who's recently had a spinal cord and they have a lot of leg weakness, rather than requiring all this work from your muscles to stand up, you can kind of lock out your hip by getting the inguinal ligament at its tightest point and have more stability in standing and not require so much from your leg muscles. Okay, but you would need the hips fully extended in order for that ligament to be supporting you in that way. So this is often how they teach people after a spinal cord injury to stand when they're starting gait training, and maybe they have braces on their legs that help them help lock them out or support them. And another functional takeaway, we've mentioned this before, but always remember you place the assistive device on the opposite side. So if there's pain in the left hip or weakness in the left hip and you place it in the right, then you actually can lean towards that side, the opposite side, and de-weight the side that you're standing on. Put less weight on that side, so you're requiring less from those muscles and also putting less weight on it to cause the pain. Common hip pathologies, you can read through these yourself if you want to pause for a second. We've covered all of these but one in Rehab 1. So the only one we did not cover, I will cover now, and that is the leg calf Perthes disease. And that's just where the blood flow to the femoral head has been disrupted. It's either been broken or blocked somehow, and the femoral head actually begins to disintegrate and die. And so that is painful, very painful, and decreases function and all that. That's called leg calf Perthes disease. Now we are moving on to the knee. Arthrokinematics, landmarks, muscles, functional takeaways, and common pathologies for the knee joint. So a few little fun facts. The knee is the largest joint in the body. Its stability is maintained by muscles and ligaments, so there's not like a true connection between the bones. Of course, you have the ligaments there, but most of the support comes from the muscles, ligaments, and tendons surrounding it. There's not bony stability. The open pack position is at about 25 degrees of knee flexion, so right about here along this line. And if someone has more than 5 degrees of hyperextension, it's considered genu recurvatum. You know, that's when you overextend the knee. So more than 5 degrees is when they consider it genu recurvatum. The arthrokinematics change whether you're in an open pack position or open chain position, or closed chain position. So when you're in an open chain, it's the non-weight bearing, and the femoral, the femur is remaining still while the tibia is moving. So the femur is fixed, the tibia is moving around it. So that would be this picture. The femur doesn't change and the tibia moves around. This is a concave tibia we'll see later that the meniscus is actually what makes it concave. The top of the tibia is pretty much flat, but the meniscus are rounded up to make it a concave surface. So the concave tibial plateau moves on the convex femoral condyles. So you know, with a concave surface moving around, everything's in the same direction. The move of the long bone, the roll, and the glide. So if you're wanting to increase extension, I'm in a flex position, I want to increase extension, then I will push it the same way as extension. So extension would be anterior, so I would do an anterior glide. This is in an open chain position if I was mobilizing just the tibia. Now in a closed chain position, so weight-bearing position, the tibia actually becomes fixed on the ground while the femur is responsible for doing the moving. Okay, so that is a convex femur because the femoral condyles stick out, moving on the concave tibial plateau. So now the movement, this is fixed, and the movement's coming from there. So now we have a convex surface as I'm going anteriorly towards extension. The roll is also anterior, but it's gliding posteriorly. Remember, the glide is in the opposite direction to keep it right in the middle of the joint. Otherwise, it'll just roll right off. And so if I was wanting to increase extension by mobilizing the femur itself, then anterior movement is what the long bone is doing. So a posterior glide on the femur, the distal femur, is how it would increase extension there as far as joint mobs. Okay, that's the arthrokinematics for the knee. Now the screw home mechanism. So this is what allows your knee to lock. Right when you're doing your last few degrees of extension, about 15 to 20 degrees of extension, the knee actually rotates laterally in order to lock. So in weight bearing, it's the tibia that rotates laterally, and what we do to remember that is lateral leg leads to locking. So if you're standing up, the tibia and the foot is planted, the tibia will rotate laterally to the outside just slightly to lock your knee. Lateral leg leads to locking. In non-weight bearing, it's the femur that rotates in the opposite direction. Typically when we're locking our knee, we're thinking about weight bearing, so I think it's most important to remember lateral leg leads to locking, but also put it in the back of your mind, that's in standing. So lateral leg leads to locking. In non-weight bearing, it would be medial rotation of the femur, but typically we're talking about weight bearing, so lateral rotation of the tibia. Once it's locked, the knee also requires it to be moved in the opposite direction to unlock. So if you're standing and you lock your legs, then you don't really focus on this. This is not necessarily something in your mind that you're doing, but your leg, your tibia has to rotate medially just slightly before you can bend it. If you lock your leg too long, before I say this, the popliteus is the muscle that does that, unlocks your leg. So once you do a little bit of lateral rotation of the leg to lock it, then the popliteus does medial rotation of the tibia to unlock it. And that's really its primary job. Popliteus helps us unlock the knee. If you do lock your legs too long, I'm sure most of you have heard of this or seen it, maybe experienced it yourself, then what happens is the venous return, because your artery and your vein are behind your knee there, the venous return decreases, so your blood volume returning to your heart decreases, which causes a quick decrease in blood pressure, which triggers your body to pass out. You know, if all of a sudden your brain is getting less oxygen, if there's less blood pressure, your automatic response is for you to pass out, because then once you're in a supine position, more blood flows to the brain. So it's like, lay down really quickly, I need more blood. So anytime you lock your legs too long, your venous return decreases, your blood pressure then in return decreases, and you pass out. And that's why in a chorus concert or in the military, you see people passing out. All right, our Boney Landmark. So on the tibia, I talked about the tibial plateau before. There's the tibial tubercle. The patellar tendon, of course, will attach there. You have your Lateral condyle, so this is the medial side. So your lateral condyle here and your medial condyle here. And then the patella. Of course, the patella is a shield-shaped bone, triangular, that's kind of floating in front of the distal femur, and it's attached only by the ligaments and tendons. So patellar tendons, and then the bottom portion of rectus femoris, that attachment site. With our ligaments, there are two different types of ligaments at the knee. There's the cruciate ligaments and the collateral ligaments. The cruciate ligaments, of course, that's your ACL and PCL. They cross each other obliquely, so at a direction making an X. They're named for their attachment on the tibia. So ACL, anterior cruciate ligament, is more anterior on the tibia. That's where it starts, in an anterior position on the tibia. PCL, posterior cruciate ligament, is more posterior on the tibia. And then they provide stability in the sagittal plane. That's what plane that they resist the movement. With the collateral ligaments, they provide stability in the frontal plane, like side-to-side directions, and they tighten during extension to increase knee stability. So the collateral ligaments are the MCL and the LCL. When your knee is extended is when they are most tight and provide the most stability. They also are more likely to be damaged in that position because they're at their tightest point. So with the ACL, again, it goes from the anterior tibia and portions of the medial meniscus. Then it travels posteriorly to the posterior femur on the lateral condyle. So anterior tibia on the medial meniscus to the posterior femur on the lateral condyle. And think about a lot of times when your ACL tears, your meniscus tears, typically your medial. I wonder why. Well, it's attached to the medial meniscus. That could be one reason. ACL prevents posterior translation of the femur. So it prevents the femur from going backwards too far. And then during knee extension is also when it is tight, just like the collateral ligaments. The PCL begins posteriorly on the tibia, and then it travels upward and anteriorly on the medial condyle of the femur. So it starts posterior tibia and then connects to the anterior medial condyle on the femur. It prevents anterior translation from moving forward too far, and it is tight during flexion. So it's the only one that's tight during flexion. Your LCL, MCL, ACL are all tight during extension. PCL is tight during flexion. So it's more likely to break in a car accident. You know, if your knee is shoved really hard into the dashboard when it's in a flex position, more like something like that falling on a bent knee, than it is in a standing position like the others. Our MCL, it attaches to the medial condyles of the tibia and the femur, but it also attaches to the medial meniscus. Remember that unhappy triad. It's an ACL tear, medial meniscus tear, and an MCL tear. They all three attach to each other, so no wonder they are torn together often. And then the MCL, of course, provides medial stability, and if you have something hit the lateral part of your knee, which would push it medially, then that is often how the MCL is torn. Is maybe if you were tackled from the side and they hit the lateral side of your knee and pushed it medially, that would be how it would be torn. Also, you know, if you do a quick stop and pivot movement, cutting movement, it can as well. The LCL attaches from the lateral femoral condyle down to the head of the fibula, and it provides lateral stability. And of course, if you have a blow to the knee medially, then it's going to push it laterally and could possibly tear it. It is a little bit thicker and not torn quite as often as the MCL, just based on its anatomy. The meniscus, so they are thick half-moon shaped cartilage, and they are thicker laterally than medially, which makes it like a little cup. And that is what makes the flat tibia or tibial plateau become more of a concave surface. See how they are cupped around the side? They're thicker laterally, and so they cup it and make it concave versus just a flat surface. Their job is to absorb shock, and of course they increase your proprioception. A lot of our neurons are held in our cartilage and help us know where everything is in space. The popliteal space, it contains the tibial nerve, the common peroneal nerve out here, the popliteal artery and vein, which remember were the femoral artery and vein before they cut through the adductor hiatus in adductor magnus. And those are the three. We mainly, when we're talking about the three, we're mainly talking about these three. Common peroneal is out to the side there. But that pass in the posterior knee. And again, these are the area, this is the area that would be obstructed slightly if you locked your knee for too long, and this is the vein that would be occluded and causing less venous return to flow back to the heart. So this is the popliteal space where the tibial nerve and the popliteal artery and vein are passing, and then of course the common peroneal to the side. And then the last little anatomical structure we're going to talk about is the Pecs and Serene, and it is the attachment site of sartorius, gracilis, and semitendinosus. So the Pecs and Serene is a little portion here of the tibia, and it is the attachment site of each of those muscles. Moving on to the knee muscles, we have the quadriceps. We already talked about rectus femoris. It's the only one that is a two-joint muscle. We have vastus lateralis, vastus medialis, and in between, vastus intermedius. They all flex the knee. All are innervated by the femoral nerve. And then rectus femoris, of course, crosses the hip and also helps with hip flexion. The others do not. I say they flex the knee. They extend the knee. I need to fix that. They extend the knee. I'm sorry. So all of these extend the knee. We know this. I don't know how I made that mistake, but all of the quadriceps extend the knee, but it also helps with hip flexion, the rectus femoris. Sorry about that. Posterior knee muscles. So we have our semimembranosus. These are the hamstrings. Semitendinosus. We just only see the tendon right here. And biceps femoris. Those are the hamstrings. They're all innervated by the sciatic nerve except for that long head of the biceps femoris. This is a typo as well, which is the common peroneal nerve. And then popliteus is also back here. We talked about it being the one to unlock the knee. We have gastrocnemius, which popliteus and gastroc are both innervated by the tibial nerve. We have plantaris, which mainly plantar flexes the foot, and it's innervated by the tibial nerve. Of course, popliteus unlocks the knee. Gastrocnemius plantar flexes the foot. Then TFL is superior gluteal nerve. I'm not sure why it's here other than the IT band crosses the knee. Gracilis is the obturator nerve, and sartorius is the femoral nerve. We covered all those in the hip lecture, but just a quick reminder of some of these muscles. Some of our common pathologies. We did cover all of these in Rehab 1, so if you're rusty on them, go back and look at those lectures, or shoot me some questions if you have any. So now our ankle and foot roadmap. We're going through the same things with the ankle and foot: arthrokinematics, landmarks, muscles, functional takeaways, and our common pathologies. With the arthrokinematics, so there is a convex talus. So your talus is in the red right here. It is convex, moving on a concave tibia. So the tibia, as you see, is concave. The open pack position is 10 degrees of plantar flexion and midway between inversion and eversion. So basically neutral alignment with 10 degrees of plantar flexion. Our ankle motions, we have dorsiflexion, pulling the toes up, plantar flexion, pointing them down, inversion, bringing your big toe in, eversion, pushing it out, and then abduction and adduction, so kind of like a windshield wiper, in and out. Supination and pronation are combined movements. So supination, we have mentioned before that we often, when we are standing in a weight-bearing position, we refer to these movements as supination and pronation. But even in non-weight bearing, if you are plantar flexing, inverting, and adducting, that is supination. If you are dorsiflexing, everting, and abducting, then that is pronation. And we often see this in standing postures where someone's foot automatically goes towards either overpronation or oversupination. The foot motions at the toes can flex and extend and abduct and adduct. And then the distal joints, the PIP and the DIP, can also flex and extend. Boney Landmark, so we still have the tibia, we still have the fibula, but down towards the ankle, the bottom portion, medial portion of the tibia is the medial malleolus, and then the bottom portion of the fibula is the lateral malleolus. So these are what make up our ankle bones. Medial malleolus being the medial part of the tibia, lateral malleolus being bottom of the fibula. Our bony landmarks of our foot. In the forefoot, we have our phalanges and our metatarsals. The portion of the metatarsal, the most distal portion, is called the head. So you can see the fifth metatarsal head. Usually people have a little bony prominence there, you can see. And the first metatarsal head typically is where like a bunion would be, that area. So to help you find those bony landmarks. And then in the midfoot, we have our some of our tarsals. So the navicular bones, the cuneiforms, and the cuboid. And then in our hindfoot is the talus and the calcaneus. And these are the tarsal bones that I just mentioned a little more clear. So you can see the cuneiforms, the cuboid, the navicular, the talus, and the calcaneus. And remember, a lot of our joint mobs use either the talus, a posterior glide of the talus to increase dorsiflexion, or the calcaneus. You can invert and evert by grabbing the bottom portion of the calcaneus and turning it in and out. Medial ligaments of the ankle, we have the deltoid ligament, which is comprised of 4 different ligaments. So we have the anterior tibio-talar ligament right in the very front, tibio-navicular ligament behind it, posterior tibio-talar ligament in the very back, and in between is the tibio-calcaneal ligament. They all resist eversion of the talus. Eversion of the talus. So that's what those ligaments are responsible for. And if you stepped and significantly overpronated, you might injure those, as well as the spring ligament down below. Sorry. The lateral ligaments, the ATFL, is the one that's most commonly torn during an ankle sprain. That stands for anterior talofibular ligament right here, ATFL. Most commonly sprained ligament in the ankle. We also have posterior talofibular ligament back here. And then we have calcaneofibular ligament down here. And if you all have ever heard of a high ankle sprain, also I think it's called a 3rd degree ankle sprain, they've typically torn the ATFL, and then they have torn the articular cartilage between the fibula and tibia that holds it together. Let me go up here. Right here, this interosseous membrane, they've torn that. If it's called a high ankle sprain, I know some guy in the NBA recently had a high ankle sprain. I remember hearing about that. They've torn the fibers that the interosseous membrane that hold the fibula and tibia together. That's a bad injury. Might have been LeBron James. Y'all probably laughing at me because y'all probably know and I don't know. Okay. So arches. We have 3 arches in our foot. The transverse arch, as in, of course, that transverse plane. The medial arch is on the medial portion and the lateral arch on the lateral portion. You always want to assess the arches in a non-weight bearing position and a weight bearing position, because oftentimes in non-weight bearing it looks like it's a nice, good arch, and then as soon as they weight bear, the arch disappears. Just because of the amount of weight that is placed on it. The plantar fascia, this is connective tissue on the bottom of the foot. And typically whenever people have plantar fasciitis, they feel pain right here at the connection site to the calcaneus. Sometimes they will also feel pain along the medial portion or middle portion or along the attachment sites to the toes. But with the plantar fascia, it has a thing called the windlass effect. Windlass is a sailing term. When a winch is wound around a drum to make the rope more tight, and when the plantar fascia is wound around the MTP joints, which is during plantar flexion, it becomes tight and assists with push-off during your gait cycle. So when you plantar flex and yet hyperextend the toes, it tightens the plantar fascia, calcaneal lifting, arch rising, foot supinating, all those things put it in its most tight position and create kind of a lever to help you push through and perform push-off during the last portion of stance phase of the gait cycle. So before your leg comes up off the ground. Posterior muscles, we have the gastrocnemius, and then the soleus, which is deep 2, which means underneath the gastroc. We also have plantaris. Plantaris, we talked about it earlier. It is up in the high portion, but it has a long ligament that goes all the way down. All of them plantar flex the ankle. All of them are innervated by the tibial nerve. The gastroc is the only one that's a 2-joint muscle, so it also assists, and plantaris also assists, with knee flexion. So remember, whenever we're trying to see is the gastroc tight or not, we check dorsiflexion, so putting it at its most lengthened state, in knee extension, and again in knee flexion. And if you have more dorsiflexion with the knee flexed than extended, that means the gastroc is tight, and that is limiting the movement. They say that most Africans have a more built up, a more large and defined plantaris, and that is what assists in running faster and jumping higher. I'm not sure that research says that, but that's what the rumor on the street is. Deep posterior muscles, and this is still the posterior view. It's just showing the foot in extreme plantar flexion, so don't let this think that we've switched to the anterior view. This is our tibialis posterior, our flexor hallucis longus, and our flexor digitorum longus. All of them invert and plantar flex the ankle. All are innervated by the tibial nerve. And then, of course, the flexor hallucis longus helps flex The big toe or the great toe, flexor digitorum, helps flex the other digits, the other 4 little toes of the foot. Anterior muscles, we have our anterior tibialis here. We have our extensor hallucis longus right in the middle, and we have our extensor digitorum longus on the very right. They all assist with inversion and dorsiflexion. They are all innervated by the deep peroneal nerve. So the ones on the back portion of the calf or the lower leg are the tibial nerve. Now here on the front portion are the deep peroneal nerve. And they all invert and dorsiflex. And then, of course, extensor hallucis longus helps extend the big toe. Extensor digitorum helps extend the 4 little toes. And the peroneal nerve is also called the fibular nerve. So if you would rather call it that, just kind of understand the words are interchangeable so you don't get confused. Peroneal nerve is also called the fibular nerve. The lateral muscles of the foot, and we're almost done. Hang in there just a little longer. We have peroneus longus, and we have fibularis brevis and fibularis tertius. All of them could be called fibularis. All of them could be called peroneus. I learned them as peroneus. So I learned peroneus longus, peroneus brevis, peroneus tertius, but you could replace that with the word fibularis and it would also be accurate. They're all innervated by the superficial fibular nerve, except for peroneus tertius, which is the deep fibular nerve and the peroneal nerve. It's interesting. The littlest one needs 2 nerves. That's what it decided to do. All assist with eversion. Longus and brevis, these 2 also assist with plantar flexion based on the way that they are attached. Tertius is attached in front. See, they are attached behind, so they assist with plantar flexion. Tertius is attached in front and assists with dorsiflexion. In the foot, there are 4 layers of muscles. I'm not going to get into knowing every muscle in the foot, but there are 4 layers. Most of the muscles are in the superficial layer, but the interossi, which is kind of like the lumbricals that we are trying to strengthen with that exercise where we're toe scrunches, where we're scrunching up the toe with our toes. That's what we're trying to strengthen there. That's in the deepest layer of the muscles in the foot. And that helps support the arch and kind of support the stabilizers in the foot. Common pathologies. We have covered all these in Rehab 1 except for pes cavus, pes planus. So that's what this picture is. Pes cavus is a high arch. A normal arch is shown here. Pes planus is a flat foot or a low arch. And then the rest we have covered in Rehab 1. So please go back and review those lectures if you want to refresh your memory. And now we have covered the hip, the knee, the ankle, and the foot, kinesiology. If you have questions, let me know. Thanks for hanging in with me.